Imagine, just for a second, the most expensive, high-stakes piece of real estate you can possibly think of. Maybe it's a penthouse overlooking Central Park in Manhattan, or, I don't know, a tiny, incredibly dense block of land in the Ginza district of Tokyo.
That is a very evocative image to start with. A good one.
In those places, every single square inch counts, right? You can't waste any space at all. And every tiny alteration you make, knocking down a wall, changing a window, it has this massive outsized impact on the value and the function of the whole property.
It creates a high-pressure environment, functionally speaking. Everything is critical.
Exactly. Well, today, we are looking at the biological equivalent of that high-stakes real estate. We're taking a deep dive into the pathology of the head and neck.
It's a really apt comparison. When you look at the chapter in Robbins and Cawtran on this, which we're unpacking today, alongside concepts from Underwood's pathology, you realize this whole region is defined by two fundamental things: complexity and proximity.
Complexity and proximity. Okay, let's break those down.
Well, just think about what is packed into this relatively small anatomical space. I mean, it's essentially the size of a grapefruit, maybe a bit larger.
Not very big at all in the grand scheme of things.
No. And yet it contains all the machinery for breathing, for eating, for speaking, tasting, hearing, seeing, even smelling. It is all right there, packed together.
And it's all overlapping. It's not like the abdomen where, you have the liver over here and the spleen way over there with some room to spare. In the head and neck, everything is practically sitting on top of everything else.
Precisely. And that creates a unique and, frankly, dangerous tension. In the leg, for example, if you have a small, benign tumor, a lipoma,
Right.
say it might be an annoyance. It might look a bit odd if you're wearing shorts.
Cosmetic issue, mostly.
But in the larynx, that same amount of tissue growth, a centimeter or two, suddenly becomes a dire medical emergency. It can completely block the airway.
So the margin for error here is basically zero.
It's incredibly thin. It's razor thin. And that's why diseases in the head and neck, even very small ones, have these outsized consequences on quality of life and, of course, on survival. And that is really the lens we need to use for this entire deep dive today. We're looking at how these tissues react to injury, how they fail to adapt, and what happens when that growth regulation completely breaks down.
And before we properly jump in, a quick educational note for everyone listening. As always, this deep dive is a synthesis. It's an interpretive guide. We're pulling the core concepts from the major textbooks, Robbins, Underwood, to give you a kind of conceptual map.
Think of us as your guides through the terrain. We can point out the major landmarks, the dangerous spots, the key routes, but you still have to hike the trail yourself. This absolutely isn't a substitute for sitting down and actually reading the chapters.
Okay, with that said, let's orient ourselves. We're talking about the head and neck. Visually, what are we really dealing with here? What are the key tissues?
We are dealing with a crossroads, a massive anatomical intersection. You have mucosa, that delicate lining of the mouth, the nose, the throat. You have bone, you have cartilage, nerves, and a massive amount of lymphoid tissue. I mean, the tonsils, the adenoids, the lymph nodes.
The body's security guards.
Right. But the unifying theme here, the thing that really drives so much of the pathology we're going to talk about, is exposure.
Exposure to what?
To everything. This is the body's primary interface with the outside world. Food, air, pathogens like bacteria and viruses, carcinogens like tobacco smoke, alcohol, it all hits the head and neck first.
So it's the front line, the absolute first point of contact.
It is the front line, and that constant bombardment, that chronic irritation and injury is what drives the pathology. It drives the inflammation, the reactive changes, and ultimately, it drives the cancers we're going to discuss in detail.
Makes sense. Let's start at the entrance then. Section 1, the oral cavity.
The mouth.
Now, I usually think of the mouth just as the place where I put pizza. It's, a mechanical tool for chewing. But the source material, it paints it more like a bustling city or a zoo.
A zoo is putting it mildly. It's an incredibly complex ecosystem. We call it the oral microbiome. And we're talking about estimates of over 2,000 different species of bacteria, viruses, fungi, all living in your mouth right this second.
That is a very crowded apartment.
And usually they're good neighbors. They're what we call commensal. They occupy the space, they take up the resources so that more dangerous pathogenic bacteria can't get a foothold. The problems start when that balance is disrupted. We call that dysbiosis.
Dysbiosis. When the neighborhood goes bad. Give me an example of dysbiosis that everyone listening would know immediately.
The most common one on the planet. Dental caries. Tooth decay.
Cavities, yeah. I feel like everyone just assumes cavities are sugar eats teeth. But the chemistry, the actual process, is more specific than that, isn't it?
It is, and it's actually a fascinating chemical process. You have specific bacteria in the mouth, particularly Streptococcus mutans, that are really good at fermenting sugars. If you eat a lot of processed sugar, these bacteria go into overdrive. And the byproduct of that fermentation is acid, lactic acid specifically.
An acid versus tooth enamel.
Acid wins. It demineralizes the enamel, which is this crystalline hydroxyapatite structure, and then the dentin underneath. It essentially dissolves the crystal structure of the tooth, creating a hole.
Now, the sources mentioned something I found really interesting about the demographics of cavities. I would have assumed that with better toothpaste, better dentists, cavities would be disappearing everywhere.
You'd think so, but not exactly. It's a tale of two worlds, really. In high-resource nations, yes, the incidence has dropped dramatically, and that's largely due to the fluoridation of public water supplies and, of course, better hygiene.
How does fluoride actually work? Does it just kill the bacteria?
Not directly. It does something much cleverer. It gets incorporated into the enamel crystal, changing it from hydroxyapatite to fluoroapatite. And fluoroapatite is just chemically harder and much more resistant to acid. It essentially upgrades the armor of the tooth.
I see. So it's a defensive strategy, but in low-resource nations.
The incidence is skyrocketing. It's a huge public health problem.
Because the diet is changing faster than the infrastructure.
That's it exactly. Processed sugars and sugary drinks are becoming much more available and affordable, but the dental infrastructure and public health measures like fluoridation haven't caught up. It's a collision of modern diet and biology. The environment changed faster than the protective measures could be implemented.
Now let's move from the teeth themselves to the gums. I feel like every time I go to the dentist, I get a lecture about flossing to prevent gingivitis. It almost feels like a marketing term. What is actually happening in the tissue?
So gingivitis is, at its core, inflammation of the mucosa surrounding the teeth. It all starts with plaque.
Which is that sticky, colorless film.
Right. But it's not just food debris. It's a highly organized biofilm. It's a constructed community of bacteria, their secretions, proteins from your saliva, and cells. It's a living structure. And if you don't brush and floss it away, it mineralizes. Calcium salts from your saliva deposit into it, and it becomes calculus, or tartar.
That hard, jagged stuff the hygienist has to scrape off.
That's the stuff. And it's physically irritating to the gums. The body responds with inflammation. You get redness, swelling, bleeding when you brush. That's gingivitis.
But, and this seems to be the key point, gingivitis is reversible.
Completely. You go for a cleaning, you get the plaque and calculus removed, you improve your hygiene, and the inflammation subsides. The tissue goes back to normal. But if you don't, if you let it fester, it can progress to periodontitis, and that is a different beast entirely.
Oh, so what's the shift?
Periodontitis is destructive. The inflammation is no longer superficial, it goes deeper. It starts to attack the periodontal ligaments and the alveolar bone, the actual jawbone that holds the tooth in its socket. The body, in a misguided attempt to retreat from the bacteria, actually starts dissolving its own bone.
So the foundation of the tooth literally starts to rot away.
Effectively. The pocket between the gum and the tooth deepens, creating an anaerobic environment. And biologically, we see a crucial shift in the microbiome. In healthy gums, you have mostly facultative gram-positive bacteria that can live with oxygen. In deep periodontitis pockets, the population shifts to obligate anaerobes, particularly gram-negative bacteria. Nasty bugs like Porphyromonas gingivalis.
That sounds like a villain in a sci-fi movie.
It acts like one. And here is the so what for everyone listening. This is not just about losing your teeth, though that is obviously a major consequence. Periodontitis creates a huge inflammatory burden on the entire body. It's been strongly linked to worsening diabetes, to cardiovascular disease, even to adverse pregnancy outcomes like preterm birth.
So a dirty mouth can genuinely hurt your heart.
Absolutely. The inflammatory mediators and sometimes the bacteria themselves don't stay local. They spill into the bloodstream and have systemic effects. It's a chronic, low-grade inflammatory state.
Okay, let's stick with the oral cavity, but move to some of the weird lumps and bumps people get. I think everyone has had a canker sore at some point. What is that pathologically?
We call those aphthous ulcers. They are incredibly common. Something like up to 40% of the population gets them recurrently.
And they hurt like crazy. Completely disproportionate to their tiny size.
They do. And visually, they're quite distinct. If you look closely, you see a shallow ulcer with a yellow-gray fibrinopurulent membrane in the middle. That's basically fibrin and pus. And it's surrounded by this very prominent red halo of inflammation.
So what causes them then? Is it stress? Biting your cheek?
Yeah.
Eating too much citrus?
The honest answer is we don't know for sure. It's considered idiopathic. But we do know it's immune-mediated. For some reason, the T cells in the immune system are attacking the oral mucosa. It definitely runs in families, and it's certainly triggered by things like stress or trauma, but the root cause remains a bit of a mystery.
Okay, what about when you do bite your cheek really hard and you get that little firm lump that just won't go away? I'm a chronic cheek biter, so I know this one well.
That is almost certainly an irritation fibroma.
Fibroma. That sounds like a tumor.
Not really. It's a classic misnomer. It's not a true tumor. It's scar tissue. It's a reactive proliferation of fibrous connective tissue. You keep biting the same spot, and the body responds by laying down dense collagen to protect it. It forms a smooth, firm nodule, and the only way to get rid of it is to have it surgically excised, because otherwise you'll just keep biting it because it sticks out.
There was another one in the notes with a particularly terrifying name, pyogenic granuloma.
Ah, yes. The name is a complete and utter lie, a historical accident.
A lie? How so?
It is neither pyogenic, which means pus-producing, and there's no pus, nor is it a granuloma, which is a specific type of inflammation we see in diseases like tuberculosis.
Pathologists just love to confuse us, don't they?
We do try our best. It is actually what we'd now call a lobular capillary hemangioma. Basically, it's a rapid, exuberant growth of blood vessels. It looks like a bright red, often ulcerated raspberry-like lump that grows on the gums, and it bleeds very, very easily.
And who gets this? Is it random?
It's particularly common in two groups, children and pregnant women. In pregnancy, we often call it a pregnancy tumor, or granuloma gravidarum.
That sounds incredibly alarming for an expectant mother to hear.
It is very alarming. Because it can grow quite fast and it bleeds, people immediately worry that it's cancer. But it's completely benign. It's thought to be driven by a combination of hormonal changes and local inflammation. It can even regress after delivery, but sometimes it needs to be removed if it's bothersome.
All right, let's shift from reactive lumps to outright infections. There is one virus that seems to own the real estate of the mouth. Herpes.
HSV1, herpes simplex virus type 1. This is a truly fascinating pathogen because of its life cycle. It's a masterclass in viral survival and persistence.
Walk us through it. What's the typical story?
Usually you get infected as a child. That primary infection, what we call acute herpetic gingivostomatitis, can be really nasty. High fever, swollen, bleeding gums, painful blisters all over the mouth and lips. It's miserable. But then, after the acute phase, the virus does something incredibly clever.
It goes into hiding.
Exactly. It retreats from the surface. It travels up the sensory nerves all the way to the trigeminal ganglion, which is a big cluster of nerve cell bodies near the base of the brain, and it just sleeps. It becomes latent. It integrates its DNA and lies dormant.
It's playing the long game.
It is. It's waiting. And then years later, you get stressed for an exam, or you get too much sun on a ski trip, or you get a cold. That physiological stress weakens the immune surveillance just enough, and the virus wakes up. It reactivates, travels back down that same nerve to the skin of the lip, and boom, you get a cold sore, or herpes labialis.
So the cold sore is really just the tip of the iceberg. The virus is essentially colonizing your nervous system for life.
Exactly. It's a permanent resident.
What about fungal infections? I think most people have heard of thrush.
Thrush is caused by Candida albicans. Now, the interesting thing about Candida is that it's part of the normal flora. It lives in the mouths of about 50% of people perfectly happily, causing no problems at all.
So why doesn't everyone have thrush all the time?
Because your immune system and your normal bacterial flora keep it in check. They keep its numbers low. Candida is the definition of an opportunist. It only overgrows and causes infection when the body's defenses are down.
So specific situations.
Right. Maybe you're on broad-spectrum antibiotics that have wiped out the good bacteria that compete with it, or you're using inhaled corticosteroids for asthma, or you have uncontrolled diabetes, or you're undergoing chemotherapy, or you have HIV. The fungus seizes the opportunity.
How do you know it's thrush and not just, say, milk tongue on a baby or something else white?
The key clinical clue is that you can scrape it off. It looks like these creamy white, cottage cheese-like plaques or membranes on the tongue or cheeks, a pseudomembrane. If you take a tongue depressor and gently scrape it, it comes off, and underneath, the tissue is red and often bleeding slightly.
That distinction, scrapable, seems really important because the notes mention another white lesion that you cannot scrape off. Hairy leukoplakia.
Yes, hairy leukoplakia. This is a very specific lesion with a very specific cause. It almost always happens on the lateral borders, the sides of the tongue. It looks like a white, feathery, or hairy patch that's sort of corrugated.
And you can't scrape it off.
Correct. It's fixed to the tissue. And it's caused by the Epstein-Barr virus, or EBV, but only in patients who are severely immunocompromised, most classically with advanced AGIs. In fact, back before we had good antiretroviral therapy, seeing hairy leukoplakia was often a clinical sign that a patient's immune system was failing and they were progressing to AIDS.
So scrape equals thrush. No scrape on the side of the tongue, think EBV in an immunocompromised host.
That's a great clinical rule of thumb, and that no scrape rule brings us directly to the most dangerous territory in the mouth, the potentially malignant precancerous lesions.
Right, this is where the stakes get very high. Section 2, oral neoplasia and the spectrum of squamous cell carcinoma.
Exactly.
The sources talk about white patches and red patches, leukoplakia and erythroplakia. Help us decode these terms properly.
Leukoplakia literally just means white plaque. It's a clinical term, not a final diagnosis. It is critically a diagnosis of exclusion. A pathologist sees a biopsy, and the clinician describes a white patch, and you call it leukoplakia if you can't scrape it off. And you can't diagnose it as any other specific disease like lichen planus or candidiasis.
So it's a descriptive bucket term for unexplained white patch.
It is, but clinically it's a huge warning flag. When you biopsy these, about 5 to 25% of them will turn out to be premalignant. They will harbor dysplasia, which means disordered abnormal cell growth that is a step towards cancer.
Okay, so white is definitely worrying. What about red?
Erythroplakia, red patch. These are much, much rarer than leukoplakia, but they are much, much more dangerous.
Why is that? Why is red so much worse than white?
A white patch, leukoplakia, is white because the epithelium is thickened and has a layer of keratin on top, like a callus. It's a protective response. And erythroplakia is red because the epithelium has become so thin, so atrophic and disordered that you are seeing the blood vessels in the connective tissue right underneath. There's no protective layer left. And if you biopsy a red patch, the numbers are stark. Over 90% of the time, it is already severe dysplasia, carcinoma in situ, or even, frankly, invasive carcinoma.
Wow, so 90% plus risk with red versus maybe a 25% risk with white?
Exactly. Red is the highest level danger signal in the oral cavity.
And what are both of these potentially leading to? The big one, squamous cell carcinoma.
The big one is right. 95% of all head and neck cancers are squamous cell carcinomas, or SCC.
Now, the deep dive here in the sources reveals something crucial, that not all SCCs are created equal. There seem to be two fundamentally different pathways to getting this cancer.
This is probably the most important shift in our understanding of head and neck cancer in the last 20 years. We used to think it was all one disease driven by smoking. Now we know there are two distinct diseases that just happen to look similar under the microscope.
Okay, let's unpack that. Let's start with pathway 1, the classic pathway.
The classic pathway is driven by exposure to carcinogens. The main culprits are tobacco in any form and alcohol, especially when used together. They have a synergistic multiplicative effect. This is the cancer you see in older adults, typically people who have smoked or chewed tobacco for decades.
This is the marinated mucosa you mentioned earlier.
That is a perfect way to put it. This leads to a really important concept called field cancerization.
I love this term. It sounds like something out of military strategy.
It essentially is. Imagine a farmer who has been treating an entire field with a toxic chemical for years and years. You might see one particularly nasty weed pop up in one spot, and you can pull that one weed out, but the soil everywhere in that field is damaged and genetically unstable.
In the mouth.
The entire lining of the mouth and throat has been exposed to the carcinogens in smoke and alcohol for years. The cells everywhere have been accumulating mutations in key genes like TP53, P63, and OTCH1. So you might surgically remove the visible tumor in, say, the floor of the mouth, but the field of surrounding tissue is still genetically damaged and primed to form another cancer.
Which means the cancer is likely to come back.
Or, more accurately, a new independent cancer is likely to start. These patients have a huge risk of developing second primary tumors. A survivor of one tobacco-related oral cancer has a 3 to 7% chance per year of developing a brand new, unrelated cancer somewhere else in the head and neck or lungs.
That is a terrifying statistic. It's like playing Russian roulette every single year after your cure.
It is, and that's why lifelong vigilant follow-up is so critical for these patients.
Yeah, let's contrast that with pathway 2. This is the one that's really changing the demographics of the disease, the HPV pathway.
Right. This is a different disease entirely. It tends to affect younger patients, often in their 40s and 50s, and frequently people who have never smoked a day in their life.
And it's driven by a virus, the
Mm.
human papillomavirus.
Specifically, high-risk HPV, usually type 16. This is the exact same virus that is the primary cause of cervical cancer.
How does the virus actually cause the cancer? What's the mechanism?
The virus produces two powerful oncoproteins called E6 and E7. I like to think of them as molecular brake cutters. They very efficiently seek out and disable the body's most important tumor suppressor proteins, P53 and RB. P53 and RB are the guardians of the genome. They stop cells with damaged DNA from dividing. Without those breaks, the cells just keep dividing uncontrollably.
And where in the head and neck do these HPV-related tumors typically show up?
They have a very specific predilection for the oropharynx. That means the tonsils, the crypts of the tonsils, and the base of the tongue.
The notes in Robbins mention a clinical paradox with these HPV-driven tumors. They present with small primary tumors but big problems in the neck.
It is a very classic presentation. The patient comes in, maybe a 45-year-old healthy non-smoker, and they have a large cystic lump in their neck, a swollen lymph node. But when you examine their throat, you see almost nothing. Or maybe just a tiny, tiny ulcer hidden away deep in a tonsillar crypt.
So it spreads to the lymph nodes incredibly early.
Very early and very effectively. But, and here is the crucial good news, despite that early and bulky spread, these patients have a much, much better prognosis than patients with smoking-related cancers.
Really? That seems counterintuitive. Why?
The biology is fundamentally different. These tumors have fewer overall mutations than the smoking-related ones. They are highly sensitive to both radiation and chemotherapy. So even patients with advanced stage disease at diagnosis have significantly higher cure rates.
Is there a specific test you can do on the biopsy to tell them apart?
Yes, and it's now standard of care. We do an immunohistochemical stain for a protein called P16. For complex reasons, in HPV-driven cancers, the P16 protein is massively overexpressed. So if the tumor lights up bright brown with the P16 stain, it's almost certainly HPV-driven. If it's negative, it's likely the classic smoking type.
So P16 is the surrogate marker. That's a fundamentally important distinction to make.
Absolutely. It changes the treatment plan, the prognosis, and how we talk to the patient about their future.
All right, let's move from the soft tissues and go into the bone. Section 3. Odontogenic cysts and tumors of the jaws.
The jaws are truly unique in the skeleton.
Because they had to accommodate teeth.
Exactly. No other bone in the body has to form these complex structures that then have to erupt through the surface and stay there for a lifetime. And because of that complex developmental process, the jaws are full of leftovers.
Leftovers, like cellular scraps.
You can think of it that way. They're remnants of the tissue that was responsible for making the teeth, the odontogenic epithelium. And these little nests of leftover epithelial cells can be stimulated to grow later in life, forming cysts and tumors that are unique to the jaws.
Let's start with the cysts. The most common one seems to be the dentigerous cyst.
This one is very logical. Dentigerous means related to the tooth. This cyst forms around the crown of a tooth that has failed to erupt, most commonly an impacted wisdom tooth.
So you take an x-ray for some other reason, and you see this dark, fluid-filled circle around the crown of the buried wisdom tooth.
Correct. Fluid builds up between the tooth crown and the surrounding dental follicle. The treatment is straightforward. You extract the tooth, you remove the cyst lining, and you're done. It's usually curative.
Simple enough. But then there's the aggressive cousin, the OKC.
The odontogenic keratocyst. This one is trouble. It used to be called a keratocystic odontogenic tumor, or KCOT, because it behaves so aggressively.
Why? What makes it too troublesome?
It has a very high recurrence rate. You go in and surgically remove it, you scrape out the bone cavity, and it still grows back in up to 30% of cases. Its lining is made of this specialized, thin, friable, parakeratinized epithelium that seems to have its own intrinsic growth potential. It's just programmed to grow.
And it's linked to a major genetic syndrome, right?
Yes, and this is critical. It's strongly associated with Gorlin syndrome, also known as nevoid basal cell carcinoma syndrome. If you see a young patient with multiple OKCs in their jaws, you absolutely have to work them up for this syndrome. They'll also have multiple basal cell skin cancers, skeletal abnormalities, and other issues. It's caused by a mutation in the PTCH gene.
PCCH, the patch gene.
Exactly. It's a key tumor suppressor in the hedgehog signaling pathway.
Let's shift from cysts to actual tumors in the jaw. What's the big one to know?
The most important one is the ameloblastoma.
Great name. Sounds like it's going to blast through the bone.
It comes from the ameloblasts, the cells that are supposed to make tooth enamel, but this tumor doesn't actually make any enamel. It just grows and grows. On an X-ray, it has a classic soap bubble or honeycomb appearance in the jawbone.
Soap bubbles. That sounds delicate and harmless.
The name is deceiving. The behavior is not delicate at all. It's technically benign, meaning it rarely metastasizes to the lungs or elsewhere, but it is locally malignant. It is incredibly infiltrative. It burrows into the bone like roots of a tree. If you just try to scoop it out, it will absolutely come back.
So it requires much more aggressive surgery.
It does. You have to resect a whole segment of the jaw with wide, clear margins to ensure you've gotten all the microscopic extensions. It can be very disfiguring surgery.
On the completely opposite, lighter side of the spectrum, there's the odontoma.
Right, the most common odontogenic tumor. And it's not really a true tumor in the scary sense. It's what we call a hamartoma. It's just a disorganized, jumbled up bag of dental tissues. It's a mass of little malformed tooth-like structures made of enamel and dentin.
Like a bag of marbles made of tooth material.
That's a perfect description. You find it on an X-ray, you scoop it out, and it's cured. It has no potential for malignant behavior.
Okay, that covers the jaws. Let's move up into the airways. Section 4. The upper airways, the nose, the sinuses, the nasopharynx.
The start of the respiratory system.
We all know rhinitis, the runny nose, the common cold or allergies.
Yes, viral rhinitis is the common cold. Allergic rhinitis is hay fever, an Ig-mediated response with lots of eosinophils.
But let's talk about nasal polyps. I always pictured these as little tumors, but the sources are clear that they are not.
That's correct. A nasal polyp is not a neoplasm. It's simply a focal protrusion of swollen, waterlogged edematous mucosa. If you see one, it looks like a peeled, pale grape.
A peeled grape.
Exactly. Shiny, pale, soft, and gelatinous. It's the end result of recurrent attacks of rhinitis, usually allergic. The tissue gets so chronically swollen and edematous that it just prolapses down into the nasal cavity.
Can they be dangerous?
Mostly they're just an obstruction. They block your breathing and your sense of smell. But the real danger is when they block the drainage of the sinuses. The sinuses are air-filled cavities in the skull, and they have tiny drainage holes called ostia. If those get blocked by polyps, you get sinusitis. The sinus becomes a stagnant swamp.
And stagnant swamps breed bacteria.
Precisely. You get a bacterial superinfection. But there is one specific and deadly type of sinusitis we have to flag, especially in diabetic patients.
Mucormycosis.
Yes, this is a true medical emergency. The fungus itself, mucor, is ubiquitous. We breathe in the spores all the time, and it's harmless. But in a patient with diabetic ketoacidosis, high blood sugar, and an acidic state, the fungus becomes incredibly invasive. It loves that environment. It invades blood vessels, causing thrombosis and widespread necrosis or tissue death. It can spread through the sinuses directly into the eye socket and the brain.
This is the black fungus we heard about in the news a while back.
That's correct. The necrotic tissue it creates often turns black. It requires urgent, aggressive, and often disfiguring surgery to debride all the dead tissue, plus aggressive antifungal medication. It has a very high mortality rate.
Let's shift gears to tumors of the nose. There's one with a very specific demographic, adolescent males.
The juvenile nasopharyngeal angiofibroma.
That's the classic presentation here.
It's almost exclusively in teenage boys. They present with severe, recurrent, often massive nosebleeds, what we call epistaxis, and nasal obstruction.
Wow, the bleeding.
The tumor is essentially a vascular sponge. It's a benign fibrous mass, but it is packed with large, thin-walled blood vessels that lack a proper muscular coat. It's also very sensitive to androgens, to testosterone, which explains the specific demographic.
So a teenage boy with unstoppable nosebleed.
You have to have angiofibroma high on your differential diagnosis.
What about the olfactory neuroblastoma?
This is a much rarer tumor. It arises from the specialized neuroectodermal cells that are responsible for our sense of smell, the olfactory neuroepithelium. These cells are located way up at the very top of the nasal cavity, right near the base of the skull.
Neuroblastoma implies primitive nerve cells.
Yes. Under the microscope, it's one of the classic small, round blue cell tumors. It can be quite aggressive and has a tendency to invade upwards into the cranial cavity.
And then there's the NUT carcinoma, which just sounds like a made-up name.
I wish it were. It's named for the gene involved, the NUTM1 gene. This is a very rare but extraordinarily aggressive and lethal cancer. It often affects young people and arises in midline structures like the head and neck or chest. It's defined by a specific genetic translocation, usually involving the BRD4 gene and the NUT gene. The prognosis is tragically poor, with most patients dying within a year.
It's terrifying how these specific rare genetic glitches can create such a monster of a disease.
It is. But identifying them, defining them molecularly, is the first step towards developing targeted therapies.
Let's finish this section with a big one. Nasopharyngeal carcinoma, or NPC. This one has a fascinating link to geography, diet, and a virus.
NPC is a classic example of a gene-environment interaction. It's very rare in North America and Europe, but it's one of the most common cancers in parts of southern China, Southeast Asia, and also parts of North Africa and the Arctic.
What's driving that geographic distribution?
It seems to be a perfect storm of three factors. One, a genetic predisposition in those populations. Two, infection with the Epstein-Barr virus, EBV again. And three, environmental factors, specifically diets rich in nitrosamines from things like salted fish or other preserved and fermented foods, especially when consumed early in life.
So a combination of salted fish, a specific virus, and the wrong genes.
That seems to be the combination. The EBV virus infects the nasopharyngeal epithelial cells, and the dietary carcinogens help promote the malignant transformation.
What's the characteristic histology?
The most common type, and the one most linked to EBV, is called non-keratinizing undifferentiated carcinoma. There's an old term for it, lymphopithelioma, which is very descriptive. Under the microscope, it looks like the large malignant cancer cells are drowning in a massive sea of reactive lymphocytes and plasma cells. It's actually the body's immune system mounting a huge, but ultimately ineffective, response to the virus-driven tumor.
And this one is notorious for spreading to the neck nodes very early, isn't it?
Extremely early. Often the very first sign of the disease is a patient presenting with a large, firm lump in their neck, a cervical lymph node metastasis. The primary tumor in the nasopharynx can be tiny and completely asymptomatic.
Okay, let's move down from the nasopharynx to the voice box. Section 5, the larynx.
The instrument of communication, a very delicate and critical structure.
Professional singers and people who yell a lot get nodules. What are those, pathologically?
Vocal cord nodules, or singer's nodules, are essentially calluses.
Calluses on your vocal cords.
Exactly that. If you chronically misuse or abuse your voice, singing with poor technique, screaming at football games, the vocal cords slam together with excessive force. The body reacts to that chronic trauma by thickening the tissue at the point of maximal contact. They are typically bilateral on both cords, right opposite each other. They're smooth and completely benign.
And how are they different from a vocal cord polyp?
Polyps are usually unilateral on just one side, and they tend to be softer, more gelatinous, and more vascular. A polyp can happen from a single event of severe vocal trauma like screaming for hours at a concert.
So the remedy for both is primarily voice rest.
Voice rest and speech therapy to correct the underlying abusive behavior, stop the trauma, and they often resolve or shrink. But the hoarseness they cause is a great warning sign. It brings people to the doctor.
We see HPV pop up here again, but different types than the ones causing cancer, right?
Correct. In the larynx, we can see squamous papillomas. These are benign, warty growths caused by low-risk HPV types, usually HPV 6 and 11. These are the same types that cause genital warts, not cancer.
But they can still be a significant problem, especially in children.
They can. They look like little white or pink raspberries growing on the vocal cords. In an adult, it's usually a single papilloma. But in children who can acquire the virus during birth from an infected mother, they can develop what's called recurrent respiratory papillomatosis.
Which means
they get multiple recurring warts growing not just on the vocal cords, but throughout their airway. It's very dangerous because they can obstruct breathing. These poor kids often have to undergo dozens of surgeries over their lifetime to have the papillomas lasered off, only for them to grow back again.
And finally, the malignant tumor of the larynx, laryngeal carcinoma.
This brings us right back to our old friend, smoking. This is almost exclusively a disease of smokers. The risk is directly proportional to the amount you smoke.
And it's squamous cell carcinoma again.
Overwhelmingly. It follows that classic stepwise progression we talked about in the mouth. Hyperplasia from the irritation, then dysplasia, then carcinoma in situ, and finally, invasive carcinoma.
Does the exact location of the tumor on the larynx matter?
It matters more here than almost anywhere else in the body. It's a matter of life and death. If the tumor arises on the true vocal cord itself, what we call a glottic tumor, the patient becomes hoarse almost immediately. Even a tiny tumor disrupts the vibration of the cord. This brings them to the doctor early when the cancer is small and highly curable.
Because the tumor is loud in terms of symptoms.
Exactly. But if the tumor arises just above the cords, in the supraglottic region, there are no early symptoms. The voice can sound perfectly normal. The tumor can grow to be quite large, destroy the cartilage, and spread to the lymph nodes in the neck before the patient ever notices a lump, a sore throat, or trouble swallowing. The prognosis is much worse.
So anatomy dictates survival. A few millimeters of difference changes everything.
In the head and neck, anatomy is destiny.
Okay, let's take a quick sidestep from the airway to the ears. Section 6.
The ears are anatomically complex, but from a pathology standpoint, we tend to focus on a few key conditions.
Let's start with infections. Otitis media. Every parent of a young child knows this one all too well.
Middle ear infection. It almost always follows a viral upper respiratory infection. The virus causes the eustachian tube, which drains the middle ear into the back of the nose to swell shut. Fluid then gets trapped in the middle ear space behind the eardrum, and bacteria that live in the nose like strep pneumonia or H. influenza can then seed that fluid and cause a bacterial infection.
Now, what on earth is a cholesteatoma? It sounds like a tumor made of fat.
Another one of our great misnomers. It is not a tumor, and it is not made of cholesterol.
Pathologists are 2 for 2 on bad names in this deep dive.
We have a long and proud tradition. A cholesteatoma is actually a cyst lined by keratinizing squamous epithelium that is trapped inside the middle ear space where it does not belong.
So skin in the wrong place. How does it get there?
It's usually a complication of chronic ear infections or eustachian tube dysfunction. The eardrum gets retracted inwards, forming a little pocket, and skin from the ear canal gets trapped in that pocket. And skin does what skin does. It sheds keratin, or dead skin cells. Normally, that dead keratin just falls off your arm, but inside a closed cyst in the ear, that keratin just builds up and up. The cyst slowly expands.
And then what happens?
It acts like a slow-motion pressure cooker. The enzymes in the keratin debris are highly destructive. The expanding cyst erodes and destroys the delicate, tiny bones of the ear, the ossicles causing hearing loss. It can even erode through the bone into the inner ear or upwards into the brain. It needs to be meticulously surgically removed.
Let's move to otosclerosis.
This is a primary disease of the bone of the inner ear capsule. You get abnormal bone deposition, a sort of bony overgrowth, right around the edge of the oval window.
The window that connects the middle ear to the inner ear.
Correct. The stapes, the tiny stirrup bone, sits in that window, and its footplate has to vibrate to transmit sound. Otosclerosis basically cements the stapes footplate in place. The bone fuses, and it can't vibrate anymore.
So sound hits the eardrum, travels through the first 2 bones, but the signal just stops there.
It's a classic cause of conductive hearing loss. It often runs in families and is more common in women. The good news is that we can often fix it surgically by removing the stapes and replacing it with a tiny piston-like prosthetic.
All right, let's move out of the skull and into section 7, the neck itself.
Neck masses are an incredibly common diagnostic puzzle for clinicians.
If you see a cyst on the side of the neck versus one right in the middle of the neck, does that location tell you what it is?
It tells you almost everything. The embryology of the neck is your guide.
Explain that.
If the cyst is on the lateral side of the neck, usually along the anterior border of the sternocleidomastoid muscle, it is almost certainly a branchial cleft cyst. This is a developmental remnant of the second branchial arch, an embryonic structure that normally disappears. Sometimes a piece gets left behind and forms a cyst.
And if it's right in the midline?
A midline neck cyst, especially in a child or young adult, is usually a thyroglossal duct cyst.
Which, as the name implies, relates to the thyroid gland.
Exactly. In the embryo, the thyroid gland starts at the very base of the tongue and then migrates down the neck to its final resting place in front of the trachea. Sometimes the tract it follows, the thyroglossal duct, doesn't fully obliterate. It can leave behind epithelial cells that later form a cyst anywhere along that path of descent.
And there's a classic physical exam trick to help diagnose this, isn't there?
There is. You ask the patient to swallow or to stick out their tongue. If the midline cyst moves upwards with those actions, it's virtually diagnostic of a thyroglossal duct cyst because that tract is still tethered to the base of the tongue.
That is a very cool party trick, pathologist style.
It works. Very reliable.
Now for my favorite word in this entire chapter, paraganglioma.
A bit of a mouthful. These are fascinating tumors of the extra-adrenal neuroendocrine system. They arise from paraganglia, which are little clusters of neuroendocrine cells scattered throughout the body.
In the neck, the classic example is the carotid body tumor.
Right. It arises from the carotid body, a little sensor that sits right in the bifurcation, the split of the carotid artery in the neck. Those cells are chemoreceptors. They sense the oxygen levels in your blood.
And under the microscope, they have a very distinct pathognomonic look.
Zellballen. It's a German word.
Zellballen.
It literally means cell balls. You see these tight, well-defined nests or balls of tumor cells, and each nest is surrounded by a rich network of capillaries and blood vessels.
Are they malignant?
Most are benign, but they can be locally invasive and very difficult to resect because they're wrapped around major blood vessels. And importantly, they have a very strong genetic link. A significant number of them are caused by inherited mutations in the succinate dehydrogenase, or SDH, genes.
Which is an enzyme in the Krebs cycle in mitochondrial respiration.
Exactly. It's one of the best examples of a defect in cellular metabolism directly driving tumor formation. It's really beautiful fundamental biology.
All right, let's wrap up with our final section, Section 8, the salivary glands.
We have the three big pairs, the parotid, submandibular, and sublingual glands, and hundreds of tiny minor salivary glands scattered all over the mouth and throat.
And there's a really important rule of thumb here, the rule of size.
Yes. It's an inverse relationship. The smaller the gland, the higher the likelihood that a tumor arising in it is malignant.
So a tumor in the big parotid gland, which is the most common site for salivary tumors,
Has about an 80% chance of being benign.
but a tumor in a tiny, unnamed minor salivary gland on the palate or in the lip
Has a 50 to 80% chance of being cancer. You have to be very suspicious of lumps in the minor glands.
Let's quickly touch on the common benign, non-neoplastic issues, stones and cysts.
Salivary stones, or silolithiasis, are just calcifications that form within the duct, blocking the outflow of saliva. It's like having kidney stones, but in your jaw. It causes painful swelling of the gland, especially when you eat, because the saliva gets produced but has nowhere to go.
And mucosius.
We mentioned these briefly earlier. It's the single most common lesion of the salivary glands. You bite your lower lip, you sever a tiny, minor salivary gland duct, and saliva spills out into the surrounding connective tissue. Your body walls it off, forming a bluish dome-shaped cyst. It's a pseudocyst, actually, because it has no epithelial lining.
Now for the real tumors, the parotid gland has a very famous one, the pleomorphic adenoma.
Also known as the mixed tumor. This is by far the most common salivary gland tumor overall.
Why is it called mixed?
Because when you look at it under the microscope, it's a beautiful, chaotic mess. You see epithelial cells forming ducts, but you also see areas that look like cartilage or bone and a lot of myxoid, sort of blue and snotty stromal tissue. It looks like 3 or 4 different tumors all mixed together in one.
Is it difficult to treat?
The surgery has to be done carefully. The tumor has these little finger-like extensions or pseudopods that poke out from the main mass into the surrounding gland. If a surgeon just tries to shell it out and enucleate it, they'll leave those little bits behind, and it has a high rate of recurrence. It needs to be removed with a clear margin of normal parotid tissue.
And what happens if you leave one of these in for decades?
It has a small but real risk of malignant transformation into what we call a carcinoma ex pleomorphic adenoma. A benign tumor that has been there for 20 years suddenly turns into a very aggressive, high-grade cancer.
Then there's the Warthin tumor,
Mm-hmm.
another one with a very specific profile.
This one is fascinating. It occurs almost exclusively in the parotid gland. It's much more common in men. And it has an incredibly strong association with cigarette smoking. Smokers have an 8 times higher risk.
What's the characteristic look?
It's unmistakable histologically. You see these cystic spaces lined by a very unique double layer of pink cells called oncocytes. These are epithelial cells that are absolutely stuffed with mitochondria. And this epithelial component is sitting on a dense background of lymphoid tissue, often with germinal centers. It's a very distinct architecture.
Okay, let's cover the big malignant ones. Mucoepidermoid carcinoma.
This is the most common malignant salivary gland tumor, and the name tells you exactly what it is. It's a mix of mucus-producing cells and epidermoid or squamous-looking cells. They can be low-grade or high-grade, and that determines the prognosis.
And finally, adenoid cystic carcinoma. The notes say this one has a creepy superpower.
It does. It is notorious for its love of nerves. It exhibits profound perineural invasion.
It literally crawls along the nerves.
It does. It wraps around them and uses them like highways to spread far beyond the visible tumor mass. This makes them very difficult to fully resect with clear margins. It often makes them painful, and it's responsible for their tendency to have very late recurrences, sometimes 10 or 20 years after the initial surgery. It's a slow but relentless tumor.
Okay, we have covered a massive amount of ground. From simple tooth decay to these relentless nerve-crawling cancers.
It is an incredibly dense and complex region, as we said at the start.
If we have to synthesize this all down for the listener, what are the big recurring themes or takeaways?
I think I see 3 major recurring themes throughout this entire topic. First is the theme of obstruction. whether it's a salivary stone in a duct, a nasal polyp in the sinus ostia, or a tumor in the larynx. Because the spaces are so tight, blockage happens early and it causes significant misery and disease.
Okay, obstruction. What's number 2?
Number 2 is irritation. The mouth and throat are constantly dealing with rough stuff: smoke, alcohol, mechanical trauma. This chronic irritation drives protective changes like hyperplasia, but when it goes on for too long, it drives metaplasia, dysplasia, and eventually neoplasia. It's the price of being on the front line.
Makes sense. And the third?
The third is infection as a driver. And this is more than just a simple bacterial infection. It's the entire spectrum. It's the dysbiosis of the microbiome causing destructive gum disease. And it's the high-risk viruses like HPV and EBV that directly hijack our cellular machinery to cause cancer.
And the final, so what, for the listener? Why does this all matter?
I think it's ultimately about fragility. We take our head and neck completely for granted, but a small 1 centimeter lesion in this area threatens your identity, your face. It threatens your ability to communicate your voice, and it threatens your very life, your airway. The pathology here is intensely personal.
And as we always do, here's a final provocative thought to leave you with.
Go back to that concept we discussed, field cancerization.
Yeah.
We tend to think of surgery as a cure. You know, the surgeon says, I got it all, and we feel safe. We cut the tumor out, it's gone. But if the entire lining of your mouth has been genetically altered and damaged by decades of exposure, is cure really the right word? It implies that your history, your exposures, are written into the genetic code of that entire tissue landscape, just waiting for the next trigger. It challenges us to think about prevention, surveillance, and risk in a completely different way. It's not just about the lump, it's about the entire damaged landscape.
The landscape of the mouth. That's a powerful way to end it. Fascinating.
It really is.
And if you want to see what Zellballen actually look like or visualize that unique architecture of a Wharton tumor we talked about, open up Robbins or Underwood to the head and neck chapter. The pictures really do cement the concepts.
Highly recommended. Seeing is understanding.
Thanks for diving deep with us today.
My pleasure. Until next time.